Using the PABST technique, my indications have been for both acute trauma as well as patients with non-union. There are slightly different methods that we utilize for whether it's acute trauma versus a delayed union, non-union, malunion, or a deformity case. When I refer to PABST for acute trauma, I'm referring to patients with an acute traumatic injury. Examples would include car accidents, pedestrian struck by automobile, falls from height, and typically these are patients with type 3 open fractures with segmental bone loss. In these cases, I'm typically not performing the precise nail procedure at that setting. And so these are patients, because of their soft tissues, other injuries, overall poor physiology given their trauma, that we are treating in a staged fashion. And so these patients would undergo debridement of their open fracture, placement of an intramedullary nail, and we will stage to precise nail PABST at a later date. Typically in the non-union setting, the patient has healed soft tissues, no open wounds, and we are able to deal with this in a single stage rather than in the acute trauma setting where we are setting the patient up when they're at their worst for their eventual PABST down the road. So in the non-union setting, we're assessing the patient's skin and soft tissue envelope, vascularity, previous incisions, scars, and other things that could affect our case. It is also possible in the non-union setting that the patient could have the need to treat them in a staged fashion, in which case it may be similar to the acute trauma setting, where a patient that may have had several surgeries already presents to me, and we treat the patient initially with a resection, Masquelet technique, for example, staging the patient to a later PABST in the coming months. So typically when considering compression versus PABST, it's based on the size of the defect. But in the compression technique, it's a patient typically that has a small defect. There's no resection planned. This is a patient with a non-union that has failed dynamization or possibly another technique where there's bone-on-bone contact and overall length of the limb is symmetric to the uninvolved side. PABST is a technique that is my preferred option when the bone defect is sizable, and the compression technique really is not an option. It is meant for larger defects, typically 2 centimeters or larger in the tibia or femur. In my practice, PABST has taken the place of standard Masquelet technique for distal tibia open fractures with segmental bone loss. Due to the traumatized soft tissue envelope and overall lack of vascularity of the distal tibia, I'm more confident that I'm able to treat the patient with less stages using PABST, taking their own segment of bone from an area outside of the zone of injury, transporting it across that bone defect.